Good morning, everyone. Good morning. For those of you who are standing, we actually have overflow space in the multi-purpose room. So this way you could be more comfortable, but we're delighted that we have such a large audience today. It's truly a pleasure for me to welcome Dr. Shereef Elnahal, New Jersey's 21st Health Commissioner, to CMSRU. Dr. Elnahal is a New Jerseyan who grew up locally in Atlantic County, being the very proud son of Egyptian physicians who immigrated to New Jersey. He graduated with honors from Johns Hopkins and earned his medical degree and his master's in business administration with distinction from Harvard University. He worked as a physician executive in the largest health care system in the country, the Department of Veterans Affairs, and as Assistant Deputy under the Secretary of Health for Quality, Safety, and Value, he managed a large workforce and a budget of more than $180 million. He was appointed to the VA by former President Barack Obama as a White House Fellow in 2015. During his time there, he spearheaded unprecedented efforts around transparency and access and performance, as well as standardizing best practices that prevent opioid dependency, improve women's health care, and enhance access to care for veterans, all very noble endeavors. He joined the New Jersey Department of Health this past January and quickly established a new vision for the department with very specific goals spinning around very key areas, including expanding the medicinal marijuana program, which you'll hear about today, eradicating the opioid epidemic, decreasing maternal mortality, and improving access to women's health care, reducing disparities in public health outcomes, a cause which is near and dear to our hearts here at CMSRU, and increasing access to health coverage and mental health care. Also expanding telehealth and other aspects of that. Women's health is a very key priority for the commissioner. Early in the Murphy administration, the governor signed legislation and had the department restore $7.5 million in family planning. He also directed the realignment of funding for a new Healthy Women, Healthy Families initiative, which focused on increasing healthy births and decreasing Black infant mortality in communities with the highest mortality rates. He has overseen significant reforms in the medicinal marijuana program, and the list of accolades and accomplishments goes on quite significantly. So please join me. We're delighted to have him here today. Please join me in giving a warm welcome to Dr. Elnahal.
Good morning. Is this on? Can folks hear me? All right. Really a pleasure to be here. I will say, first and foremost, that this is the biggest room that I've spoken to in these grand rounds. So clearly the level of interest and engagement here at Cooper is something to be commended. I want to thank Dean Raboli, first and foremost, and Cooper Medical School leadership for inviting me here today to discuss this topic with you. It's something that is important to me, important to the governor, and most importantly, important to patients and their families who benefit from medical marijuana every day. I also want to thank, of course, the health system leadership here, Kevin O'Dowd, Dr. Mazzarelli, and others who have made this possible and really want us to be able to spread the word to healthcare providers here in the system on how to engage in the program. To sort of survey the audience, how many folks here are medical students? Wow, fantastic. Good chunk of the room. How about residents? Great. Faculty, attendings? All right. It's almost like you segmented yourselves in the room. So that's great. I love having a mix of folks in the trajectory of training. I do believe that medical marijuana will be a routine part of clinical training, especially in New Jersey, and especially if we do our jobs the right way at the department to expand the program and to expand access to education and information about the program and medical marijuana and its benefits. This is the typical list of learning objectives that you get at the start of a medical school course or a CME credit. What I want to do is instead introduce this topic with a story. And that story is a child named Jake Koenig. Jake is no longer with us. He had metastatic Ewing sarcoma. As a radiation oncology resident, I took care of many of these patients. He had a particularly aggressive form of Ewing's, metastasized to his brain, to his skeletal system, various organs, and was in a state in a matter of months to weeks before the end of his life that was unbearable. He couldn't eat, he couldn't interact with his family because of the pain that he was living with every day. He had trouble with nausea, he had trouble with loose stools, which were severely impacting his quality of life. And he was on the usual cocktail of medications that are FDA approved that we can prescribe every day to treat many of these symptoms. Of course, these medications cause their own side effects, amplify some symptoms, dampen others. And his family just grew extremely frustrated at having to see their child go through this. The parents then discovered medical marijuana was an option for him. Cancer has always been a diagnosis for which folks can receive medical marijuana, children included. After going through weeks and weeks of bureaucratic hurdles, they were finally able to get medical marijuana to Jake. And that was the one therapy that allowed him to be a child again in the weeks before the end of his life. He was able to get out of bed, play with his parents, the rest of his family. He was able to eat. He was able to go through the day without having to suffer from the pain he had. And it was all due, according to Jake's parents, with whom I keep in touch, to medical marijuana. So that is why we are doing this. It's why I am here. It's why I think education on medical marijuana and its benefits is so important. It's for patients like Jake. There are a lot of stakeholders involved. There's the marijuana industry, there are the physicians, there's the state government. All of that set aside, it is for the patients. I want to communicate some of the key accomplishments we've been able to have with this program since the beginning of the Murphy administration. 31,000 patients now in the program. We started with just shy of, I think, 18,000. So increasing vastly the number of patients who are in the program and receiving the therapy. An increase of 12,300 since the beginning of the administration. We now have over 700 physicians in the program. We've grown that by over 100 since the beginning. I want that number to go up significantly and hope that these grand rounds will convince folks to get into the program. We have 1,200 caregivers in the system. These are folks that can go to a dispensary and obtain the therapy on behalf of a patient. And we've done various reforms to expand that number, including allowing 2 caregivers per patient instead of 1. By the way, for FDA-approved drugs that you prescribe, anybody can go pick up a lot of these drugs from the pharmacy for patients. And so we have to work with an alternative framework, but we're doing that. We have 6 alternative treatment centers. That is the name for the dispensaries. They are vertically integrated. They grow marijuana, they harvest it, they cultivate it, and they dispense it to patients. And they also consult with patients on their clinical conditions in a very much an analogous role as a pharmacist would for a drug that you might prescribe for your patients. And they help patients choose strain, the formulation, and other aspects. They are really clinical centers. And if you have a chance to tour the alternative treatment center closest to here, I would encourage all folks across the spectrum to do that, students through physicians. And we also have 4 alternative treatment centers that are currently in the application process to open satellite centers. So I mentioned they do everything from growth to dispensing. We've also allowed for satellite centers to dispense it as in a different location from where it's grown and where the other pieces take place. Again, all with the motivation to expand access. This slide goes through the top 5 conditions for which patients are receiving medical marijuana. You have to have one of the qualifying conditions as a patient for you, for a physician to recommend it. Again, not similar to a lot of other drugs, most other drugs, but that's how we are administering it here. The number 1 diagnosis is intractable skeletal muscular spasticity. What that is a reflection of pain. And in patients where physicians genuinely noted spasticity, that is the diagnosis they had to list before in order to give medical marijuana for pain control. Medical marijuana is an extremely effective agent for pain, and that's why you see that diagnosis as first. But you see as a close second, since we've added chronic pain as an independent diagnosis, that already it is grown to a point to be the second most common diagnosis, chronic pain related to musculoskeletal disorders, and will soon eclipse muscular spasticity. We have anxiety as third, PTSD, and then other forms of chronic pain thereafter. I want to direct your attention to the upper right-hand corner, the age distribution of our patients. Most notably, the most common age group is age 41 to 60, middle age, where chronic conditions are beginning to hit hard for patients. There's a lot of patients that you will see in this age group, and that represents, just like it does for treatment for other conditions, the majority of patients that you're seeing in the program. You also see about a quarter of the patients who are senior citizens, so above the age of 61, again, with their slew of medical issues benefiting. Just over a quarter are younger populations, so age 18 to 40. So cynics on the program would try to say that this is just a roundabout way of getting legalized recreational use. The age distribution here doesn't speak to that. In fact, it speaks to people with real medical problems based on the age distribution that we're seeing. And less than 0.5% of the patients are children. And you'd want to see, of course, a much lower percentage because the risk profile for marijuana for children and adolescents is much higher than adults. But of course, there are indications for which you should do it, like Jake's that I mentioned. 55% are men and about 45% are women. Here are the formulations of medical marijuana. This is one of the things that needs to be demystified, especially to the physician community. Of course, you have the flower or the bud. So the marijuana plant, the leaf itself is not the actual marijuana. You have to wait until the flowering stage, and the bud or the flower itself is what you extract. That has THC and CBD, the active components. So that is administered to patients. It can be vaporized, baked, smoked, made into oils, and people use it for all of those things. But there are also other formulations. So many of the ATCs have lozenges. What we mean by oral here is that actually people are putting lozenges that dissolve in the mouth and are absorbed in the mouth, like many other medications your patients may take. We distinguish that from edibles. Edibles, of course, are digested and go through the liver and are metabolized. For whatever reason, the initial legislation that authorized marijuana for medical use limited edibles to children. So we're working under that framework. We're trying to change that. Legislation at the state level that's being proposed will allow edibles to be offered to adults as well. There are topicals, oils, ointments, and other formulations that are meant to treat focal pain, musculoskeletal pain, joint pain, pain on the skin, etc. And the other piece to mention available to adults is now a vapable form of the oil. Previously, patients were taking the topical formulations, putting that into vaporizers and vaping it, which we didn't want because we didn't know exactly what they were getting. And so now we have a vapable form. We try to discourage smoking and vaping in favor of these other formulations, but for patients that prefer to do that, that is now available. It's something we can track better. These are the two primary active compounds for marijuana therapy. We have THC and CBD, tetrahydrocannabinol and cannabidiol. The key thing with the marijuana bud is that heat is needed for change from the precursor molecules to these active molecules, which is why you can't just take the flower bud itself, eat it, and expect something to happen. There needs to be either baking, heat from making it into an oil, smoking, vaping, etc. Heat is a necessary aspect of the process in generating the active compounds. THC is the compound that does have therapeutic effects. It's better for pain control. It's better for appetite inducement in patients with cancer, for example. It is also the compound that generates the high, quote unquote, alteration of sensorium, comes from THC. CBD is a different active compound that is particularly effective for certain types of pain, but also for anti-seizure activity. And folks that do not want to be altered, we should be picking strains that have a high CBD to THC ratio, and I'll go into what that means in a bit. There are also ways to classify it by plant type, so the way the plant itself looks has generated classifications such as indica and sativa. Generally, indica plants tend to have a more depressive effect, so are good for patients who have trouble sleeping from the various disorders that they may have, but in general, calm people down and make them want to sit on a couch and watch TV. The sativas are much more uplifting, so they trigger the sympathetic nervous system, so patients may notice an increased heart rate, but also have some of the therapeutic effects as well. Not an ideal way of classifying the therapy because there's a lot of variation between indicas and sativas in terms of their effect. Rather, the chemotypes are the much more important way of classifying them. And again, it's based on the relative presence of the two active compounds, THC and CBD. And we express that in terms of a ratio. This is what the lozenges and edibles look like. They come in forms that look very much like other medications at dispensaries. Again, you can get all three types of chemotypes, but depending on what the consultative professionals recommend at the ATC and what you recommend as the physician. These are the oils, so again, to be applied topically. This is how they look when patients get it from the ATC. Ointments as well, particularly useful for joints, again, applied topically. So that's just an introduction to say it's not people getting the normal green bud that you see whenever marijuana is depicted in the media or wherever you might see it. There are other ways that people dispense it, and those dispense methods are becoming much more common as we're getting more and more patients in the program with intractable symptoms that haven't been able to be treated. So this section is called Why Go Green? Because research, of course, informs the way we practice medicine. And there is a body of research that supports medical marijuana's use for multiple conditions. This study looked at chronic pain, and it was a meta-analysis of sorts that was published in 2013 that looked at a number of studies that investigated marijuana's effects for pain control. And so they looked at 56 hits that they generated. About 38 were randomized controlled trials for different conditions, and they noted that 71% of trials that looked at marijuana's effect on pain control compared to placebo noted an improvement. So clearly, it's an agent that works for pain control. This study looked at folks with HIV/AIDS and various symptoms associated with that. These are folks with a high viral load and high symptom burden. So looked at eating occasions and increases in appetite, and it's also its effect on sleep. And so there were two agents investigated here, dronabinol and actual smoked marijuana. Both dronabinol and marijuana had statistically significant improvement, led to statistically significant improvement in eating occasions and caloric intake. Also, the objective sleep time, while an increase was noted, was not statistically significant. The perceived sleep time and the quality of sleep showed an improvement. And HIV/AIDS is one of our conditions. Another study that looked at this population looked at it for neuropathic pain. Marijuana is both useful for inflammatory pain and neuropathic pain. So randomized to receive either placebo cigarettes or cannabinoids 3 times daily for 5 days. And smoked cannabis reduced daily pain by 34%, and most notably, these findings are comparable to oral drugs that we use for chronic neuropathic pain, the gabapentins of the world. This study looked at rheumatoid arthritis, again, another inflammatory condition. Marijuana has anti-inflammatory effects. This was the first randomized controlled trial looking at a cannabis-based medicine and treatment of RA symptoms. And essentially a blend of whole plant extracts were delivered in equal amounts, THC and CBD, compared to placebo for a period of 5 weeks. And so the DAS-28, a standard measure of disease activity, improved for folks getting marijuana compared to control. And so called for larger scale research. Rheumatoid arthritis is one of the conditions for which you can prescribe it here in New Jersey. This looked at another inflammatory condition, inflammatory bowel disease. A small series of 13 patients were administered 2 quality of life questionnaires measured before and after cannabis initiation and looked at the effect after 3 months of treatment. 4.3 kilo on average weight gain and improvements in social functioning, ability to work, physical pain associated with inflammatory bowel disease. And so again, one of the conditions for which you can recommend it to patients. This study looked at epilepsy. Marijuana also has anti-seizure activity. And so 213 patients is an open label expanded access study. All of them had a treatment-resistant form of a seizure disorder. Lennox-Gastaut is one example. They were prescribed cannabidiol and liquid daily dose that was gradually increased up to a certain level. 137 patients completed the study. Seizures decreased by an average of 54%. These are folks that had treatment refractory seizure disorders. Quite effective. This study looked at a agent called Sativex. It's a type of nabaxamol type of marijuana therapy. 19-week double-blind randomized placebo-controlled parallel study group, a well-designed study, large enough study to get some good conclusions. 272 of the patients, about half or a little over half, achieved a greater than 20% improvement after 4 weeks with this study. And so not only did this demonstrate improvement for this population, this is for multiple sclerosis, but also it created a model study design for use in future studies. And again, multiple sclerosis, an important neurologic condition for which you can recommend marijuana in New Jersey. This is a larger epidemiological cross-sectional look at the effect of the availability of marijuana, the association with the prescription of opioids in the healthcare settings. 2 big studies were published this year, both in JAMA, looking at that correlation, the availability of marijuana and opioid prescribing. This study looked at the Medicaid population, and what was noticed at the end is over 6% lower rate of opioid prescribing in states with marijuana available, leading to an argument that people are recommending it as an alternative to opioid treatment for pain, and spoke to the potential for expanded medical marijuana programs in achieving that in other states. This is a similar study, looked at the Medicare Part D population, slightly different endpoint, which looked at daily doses filled of an opioid and morphine equivalents, 3.742 million fewer daily doses filled in states that had medical marijuana programs versus states that did not. And so again, adding more evidence to the causal pathway that if you have marijuana available, physicians tend to use it in lieu of opioids. And this is actually an earlier study for which these studies are promoting a possible causal pathway. This looked at opioid overdose deaths from 1999 to 2010. It was published back in 2014, again in JAMA. And what you notice here is that you have a lower opioid overdose death rate in states with marijuana that's available medically. And what it also shows is that the effect increases over time as these programs expand. Again, another major motivator for us to expand the program here in New Jersey. So the National Academy of Medicine, formerly the IOM, saw that they were getting so many questions and inquiries about this because medical marijuana, as you know, is federally illegal at the state level, legal in many states. And, you know, there's a call for research, there's a call for better evidence. The studies I mentioned are pretty small and do not speak to the potential for better research and insight we could get with larger studies. And so the Academy looked at it, published a great report, came out last year, did a comprehensive review of scientific evidence, looked at the current quality of research, which leaves much to be desired, but also outlined gaps that will allow us to improve research and gain better clinical insights. The first recommendation they gave was you need to address research gaps through effective public-private partnerships. This is where we're going to need to partner as a state that administers this program with universities like Cooper to actually conduct research and to surveil patients over time and get more and more clinical insights from studies. And so that was the first recommendation that came out of this, and we're beginning to do that in New Jersey. Also recommended to improve the quality of research by setting standards for how research studies should be set up so that we can start to do federal level registries and treat this as a condition that, an agent just like any other, for which we will want to know its effects on patients, including the risks, by the way, long term. Recommended that we improve surveillance capacity. Again, sort of the phase 4 clinical trial approach you would for any pharmaceutical that requires data, requires you to follow it over time. And the most important research barrier is that it's still a Schedule 1 drug at the federal level. Part of the definition of a Schedule 1 drug is that it has no medical application or therapeutic benefit. We know that that is not true. That is an archaic classification, and it needs to be changed. And so part of our efforts is advocating federally to change that. Senator Booker from New Jersey has been front and center in helping us do so. He has a draft bill that is starting to get some more looks from both sides of the aisle, understanding that this is a therapy that is objectively improving lives. Also called for a minimum data set to do observational studies. And so in New Jersey, we have something called the Integrated Public Health Database that is combining both clinical data and state level information on each individual in the state to a database that you can do, off of which you can do observational research. We want to combine all the data we have on the medical marijuana program. By the way, we track inventory from the initial planting and growth to dispensation, and we know what strains people are getting. So we have all that information by individual, tying that to all the other information you can get about someone clinically is extremely, extremely fruitful. And we're going to do that here in the state in partnership with universities such as this one. We also want to develop uniform terminology for clinical and epidemiological research. Unfortunately, we're still resigned to the names of the strains which came out of the whole marijuana world, names like Purple Haze and Green Jedi. And so if you're recommending with your prescription this type of thing to your patients, you don't really want to be writing that on a prescription pad or in Epic. And so what we need to do is just better classify these strains by chemotype. Again, the active compounds are THC and CBD. What is the relative presence of each of these? How can we scientifically classify these strains going forward? And so that was an important recommendation. I want to go through side effects, short-term, medium, and long-term, to give you an idea about the comparison of drugs that we routinely prescribe for patients and for which there is much less stigma versus marijuana. So in the acute phase, if someone smokes or takes it medically, they can be sedated, they can have short-term memory, impaired motor coordination, altered judgment, and paranoia. Compare that to benzodiazepines, sedation, dizziness, confusion, loss of orientation, loss of consciousness, weakness, and falls in the elderly that many of you are aware of in your clinical experiences. Opioids, a similar slate of symptoms, add potentially debilitating constipation and respiratory depression, an overdose and death. Steroids, again, common agents for the inflammatory conditions I talked about, fluid retention, hypertension, mood and memory and behavioral changes, insomnia, blurred vision, comparable at the least, if not worse, for these other drugs. In the long term, there are some studies that associate a slightly greater risk of developing a psychosis for chronic heavy marijuana users, but it's still important to list increased risk of social anxiety disorder, again, for heavy users, longer lasting cognitive deficits, especially use by adolescents and children, and by pregnant women on the fetus, and increased risk of bronchitis for those who smoke, chronic bronchitis. The other agents, cognitive impairment for benzos, adverse effects on sleep, depression, anxiety, mental health conditions, risk of severe withdrawal, which can be fatal, as many of you know, after only 1 month of regular use. Opioids, needless to say, 87% increase in all-cause mortality from overdose deaths and other mortality. And steroids, the long-term effects of steroids can be quite debilitating. You have an increased risk of infections based on adrenal suppression, diabetes, suppressed adrenal gland hormone production, thin skin, bruising, slower wound healing, a lot of symptoms associated with long-term steroid use. And then finally, the most sobering slide, addiction, withdrawal, and overdose. Nationally, overdose deaths in 2015 exceeded 8,000 for benzos and exceeded 22,000 for opioids. There has not been a single reported case of a marijuana overdose death, 0. And so an important thing to understand with this therapy. Admittedly, we need better research, we need more research. I would love a randomized controlled trial for every indication that I have to give someone an agent, a therapeutic agent. Across the board, only about 20% of the things we do to patients in hospitals have an RCT supporting its use. Not to say that RCTs are not needed for clinical practice. We want that percentage to increase over time. But to give you an idea of the benefit-risk profile, understand that the risk profile for marijuana dwarfs that of these other agents, especially for long-term risk. However, contraindication, a relative contraindication in my mind is its use in pregnant women, based on a simple dearth of knowledge about what it can do to fetal development and cognitive development of children. There's some early evidence to suggest that that is impaired in women who use marijuana for recreational purposes, who are pregnant. And so that threshold would have to be extremely high for you to recommend it to a pregnant woman for that reason. Same goes for its use in children, by the way. The use of it should be sparing, should not be first line for things like childhood anxiety. If you have terminal cancer like Jake did, it's a different risk-benefit profile. But that's why less than 0.5% of the patients we have are children. I mentioned the barriers to research, the fact that it's a Schedule I drug, the fear of federal law enforcement actions on institutions in encouraging and allowing for patients to self-administer, for example, in hospitals, nursing homes, other federally regulated institutions. That is something that would go away in a large part if it was descheduled at the federal level. We are doing what we can in New Jersey to try to decrease these barriers. We're working with the Attorney General Office on regulatory descheduling here at the state level. We're working with academic medical centers on research, and of course, we're trying to collate all of the clinical data that these patients experience through something called the New Jersey Healthcare Information Network. It's the big interoperability initiative that the department is undertaking, and a key thing will be to connect that information with our marijuana data. And a new area of research is in a type of chemical compounds called terpenes that are being used to classify marijuana in addition to the chemotype, THC and CBD. We're learning more about that and how that can further be used to stratify what you can use for patients. So I want to go through Executive Order number 6. The governor had a lot of things to choose from in terms of his initial executive orders. The sixth one he published was on medical marijuana. He directed me and our department to do an audit of the program when we came in. We had a 60-day timeline to do that, and we released the results in March of this year. We recommended 3 sets of actions to expand responsibly the program and extend access to patients: immediate actions, regulatory actions, and statutory actions. And in that order, the speed by which we could implement them. And what we did immediately was we expanded the number of conditions. I'll go into those in a second. We reduced the fees for patients to register and obtain their card, which certifies them as a medical marijuana recipient. We've made physician names optional in terms of publication in the registry. Interestingly, the vast majority of patients do want to be published in the registry to communicate to patients that they can get medical marijuana therapy. But if you don't want to be, quote unquote, a marijuana doctor on this list, you don't have to be listed, and you can choose to tell us that you do not want to be listed. We have ATC satellites now allowed, and I mentioned 4 applications for that in process, and we're now allowing 2 caregivers per patient, as I mentioned. And we've had a lot of improvements. So we're expanding access, as I mentioned, from the patient standpoint, now over 31,000. But from a dispensary standpoint, we're going to need to have more supply to catch up to that demand. And so we got 146 applications for 6 spots in this most recent round. We had to publish the names of the applicants yesterday. We're also, I mentioned, we're not requiring doctors to be listed. We're allowing for provisional caregiver status, especially for terminal patients. Patients who need access to the therapy quicker than others can now receive it. We're expanding product types, as I mentioned. We're giving mobile access to patients, especially low-income patients. The way that they access the internet oftentimes is through their phone, and their ability to register and understand the program is there. And revised rules as well. We have a lot of regulatory actions that we need to publish, and the changes that we're looking for from a regulatory standpoint include streamlining the process for me to be able to approve new conditions, especially conditions for which we know it works and we just want to expedite the approval to get it to more patients. We're allowing for separate endorsements now for different types of people, dispensaries and businesses that want to get into it. People who only want to do growth, only want to do the cultivation and extraction, only want to do the dispensing will soon be able to apply for that. And we're going to have a request for application soon on that. We're eliminating the 10% THC limit. That was an arbitrary limit set by the initial legislation. As physicians and as dispensaries consulting with patients, there may be a very good reason to exceed that limit depending on the clinical profile. And finally, we eliminated the psychiatrist evaluation requirement for minors. That was originally prescribed in the legislation. It's still the case. We eliminated it through regulatory changes, which is exciting. For patients like Jake, having to wait several weeks when he only had several weeks to live to see a psychiatrist to be able to get the therapy was inexcusable. Just like you would for any other therapy, you don't have any bureaucratic requirements for getting another evaluation for you to be able to prescribe something. We want the same environment for medical marijuana. And that's not to say that we should be extending access significantly to children and prescribing it willy-nilly for children or first line for a lot of conditions, but to say that you should have the choice as physicians depending on the clinical presentation. And then finally, the statutory changes we need. So we want to allow edible forms for everyone. We want patients to be able to access more than one ATC. We want marijuana as a first-line treatment for qualifying conditions, should a physician choose to do that. We want to eliminate the 2 ounce per month limit, especially for terminal patients, just like our standard of practice is for opioid therapy for patients who are terminal. In terms of symptom relief, we want the same standards to apply for medical marijuana. And we're raising over time the limit for others, and we want to remove the nonprofit requirement for the original ATCs so that they can have the financial and business flexibility to be able to expand production and access to patients. All of these are reflected in some way in the legislative proposals, and we're very encouraged by that. We're also looking into redesigning the patient and physician portal to make it easier and more user-friendly. We're looking at the prospect of home delivery. There's draft legislation now that would allow for that, but we're looking at the implications for the medical market. We want to be able to use external labs for quality control. A big piece to be able to tell your patients is to say, you have, of course, an option to go to the black market if you want to get marijuana. You don't know what you're getting. And some of that stuff can be laced with dangerous things like fentanyl, and we've seen that. So what this does is it allows for the assurance that you have quality testing, contaminant testing, mold testing, and you know exactly what you're getting in terms of the strain and that it's a pure, effective product. We are looking into the elimination of the sales tax to reduce the point of sale costs. That is a huge factor on whether people to choose to go to the black market or go through our program, and lowering those costs is a big priority. The fact that we have an application process now for 6 new ATCs means that supply will grow and market dynamics will hopefully reduce the price at the point of sale. Unfortunately, patients have to pay cash for this because insurance doesn't cover it because it's federally illegal. So the implications of the scheduling go far beyond what I initially mentioned in terms of patient access. And then finally, we want to streamline the background check process, make sure it's thorough, but not limiting in terms of the folks that want to get involved. Physician requirements to be in the program, only 3. You have to have an active New Jersey medical license. You have to have an active controlled dangerous substance license, registration, also given by the Attorney General's office. And you have to practice within the state of New Jersey. Have a professional address in the state of New Jersey. That is it. You don't have to go through any other certifications. Of course, attending lectures like this and learning more about it is important, but that's all you need, and that's all that's reflected in the 3-minute application it takes for you to get into the program. The same amount of time it took for you to register on Amazon or Apple, it takes for you to be enrolled in the program. Patient qualifications, they have to be New Jersey residents. So many of you here may have patients from across the river in Pennsylvania. Unfortunately, they can't engage in our program. Pennsylvania has its own medical marijuana program. They have to have a bona fide relationship with a physician and have a qualifying medical condition. So what does bona fide mean? The first 2 definitions are stupid, so I'm not going to go into them. The third is the one that everyone should look at. Basically, if you, through a thorough medical history and physical exam, assume responsibility for providing the right care to your patient for their condition, you can recommend it. And that is the case for literally every patient that crosses you in your clinical settings. You're doing a thorough assessment, you're doing a history, a physical, and you're documenting that in a note. That's all you need to prove a bona fide relationship with a patient. And that's the one that I want you to keep in mind. For no other therapy do you require some bureaucratic threshold of having seen a patient for X amount of time or X number of visits. And that's what the first 2 say. But you could get by with just the third definition. This is the exhaustive list of qualifying conditions. Many of them I mentioned the evidence for already. I'll direct your attention, though, to the new conditions that we added in March that I signed into practice. Chronic pain related to musculoskeletal disorders and visceral origin, migraine, anxiety, and Tourette syndrome. So these are new conditions that have vastly expanded access, mostly chronic pain and anxiety since we added them. And so among the over 13,000 new patients we have in the program, I mentioned chronic pain from musculoskeletal origin is tops the list. Then you have anxiety, and then you have the other ones. And so just give you an idea that chronic pain, especially from musculoskeletal origin, is going to soon eclipse the other diagnoses. A quick word on the use of medical marijuana for opioid use disorder. It's currently the case that if someone has an opioid addiction due to the fact that they were prescribed opioids for chronic pain, that you can prescribe now, you can recommend marijuana for that pain, and they happen to be addicted, and if it has some effect on getting them into recovery from addiction, great. What we're considering is adding it as an independent condition, opioid use disorder, if your patient is also on medication-assisted treatment. At the state level, both me, Commissioner Johnson, and others across the government are pushing for a massive expansion of MAT, an evidence-based treatment to get more people who are addicted to opioids into recovery. So as long as you're in some sort of MAT treatment, you can use medical marijuana as an adjunct in this proposal. And the Medical Marijuana Review Panel is still reviewing that. We hope to come to a conclusion and an announcement soon on whether we'll be able to do that. So I take the recommendations of this panel seriously, and we're consulting them on that. And so OUD actually has already been petitioned to us, so it's ready to go in terms of an assessment, and the review panel is reconvening soon to assess it. These are our review panel members, a highly respected group of physicians and healthcare practitioners that rigorously review the implications of adding new conditions and make recommendations to me and to the department on what we should be adding. And they need to be petitioned in order to do that, but often they're petitioning things to themselves because they know about the spectrum for which this is being used across the country. This is the physician portal. Again, 3 minutes. If you have your medical license in front of you and your CDS license, even potentially less, 30 seconds, who knows? But that's all it takes. Filling this out and pressing the submit button will get you into the system, and you'll be able to recommend it right after that to patients. So I encourage folks to do it, even if you're not ready yet to recommend it to patients, to be in the system, to have it as an option. I want to go over the very rigorous testing that we do of the product. We collaborate with the Department of Agriculture. We co-administer the state lab, and we test for the cannabinoid profile, metals, pesticides. We also collaborate with agriculture to test for mold and other contaminants. Again, every patient receiving product has received tested product from the ATCs that make sure that none of this stuff is in there and knows the exact cannabinoid profile. So again, an argument to make for paying extra money to get medical grade and medical quality product. And by the way, most patients who may have been obtaining marijuana on the illegal market for their symptoms, I had many of them in Maryland when I was practicing there as a resident. This is an incentive for them to engage legitimately in our program. And by dispensary, there are hundreds of different types of strains. Each of them have different strains based on their unique patient needs. Some guidance on dosing. First of all, emphasize oral administration first, vaping second, and smoking third. We discourage smoking. As a public health official, I discourage smoking. Some patients insist on doing it. I will say that people who smoke cigarettes can go through a pack a day easily. It's hard to go through a pack of marijuana cigarettes per day. That would be quite debilitating. And realistically, people are only going through about two-ish, if not just one, per day who are on this program. So in terms of the exposure to carcinogens from smoking, it's much less for marijuana. That being said, discouraging smoking. For oral administration, make sure you start at a low dose, 2.5 milligrams, especially if they want to limit their impairment, and otherwise 5 milligrams. It's important to understand that oral administration can take 2 hours to take effect. And what folks in Colorado have told me from a public health standpoint, the cocktail that they give to people with marijuana overdose, people who show up in the fetal position because they ate too many brownies thinking that it wasn't working. They give them a bottle of water, a sandwich, a dark room, and a TV for 4 hours, and that's the treatment for marijuana overdose. It's a serious protocol that emergency rooms across Colorado use. So that's the profile of a marijuana overdose. Compare that to the opioid overdose cases that many of you may have seen in the emergency room. Completely different. That being said, quote unquote overdose happens from ingestion because people are not immediately feeling the effect. And it's important to explain that to your patients. And certainly the ATCs do. And for vaporization and smoking, no more than 2 to 3 inhalations, one at a time, with a few minutes in between to make sure it's not too much at any one time. And again, as I mentioned, CBD does not have the effect of altering sensorium. So for folks who do not want that, and many of our patients don't, then recommend high CBD to THC ratio agents. And that's my presentation. I'm happy to take questions, and thanks so much for your time. The question was, can nurse practitioners also recommend the therapy? We technically don't use prescription because that has all sorts of federal definitions associated with it. But currently only physicians can recommend it. And that is because of the initial legislation. So it's one of the limiting things that we saw with the original legislation a number of years ago. There are proposals to expand that to other types of professionals, nurse practitioners included. So that will depend on a bill that's passed and signed. Other questions? Yes, to the left.
Can you comment on respiratory diversion?
Yeah. So do you mean diversion by people in the alternative treatment centers or by patients to other people?
Patients to other people. So people
Yeah.
with legitimate diagnoses releasing medication to those that want to use it for recreational.
Yeah. So the question was, what is your view on the risk of diversion for patients basically selling it to other people or giving it to other people? I would say that's quite unlikely, and the only reason is the adult use illegal market can provide marijuana at a much cheaper rate. So for people who want to get it to get high, they're most likely going to a parking lot or buying it from someone. This is expensive. It is higher grade, higher quality. Patients are getting it for that quality. And so the risk of diversion in that sense, it doesn't make as much sense to me that is a huge risk. Of course, it's important to keep it tucked away safely from children. And that's something that the ATCs advise, physicians should advise, because of course taking your parents' supply is something that kids might want to do, and we of course want to discourage that and prevent that. Yes, in the front.
So there seems to be a fair amount of misinformation out there also about medicinal marijuana. I mean, there certainly are some side effects, including the risk for increased incidence of metabolic syndrome. I'm a palliative care doctor working in the cancer center. I've heard a number of patients concerned that this is being withheld because it cures cancer, and there seems to be a lot of misinformation out there. Can you comment on that?
Yeah. So there are narratives that it does increase the risk for metabolic syndrome. There are narratives that it has anti-tumor effects. There's some preliminary basic science research that is supporting that. I didn't put that in here because it's not proven clinically to do so. So what we're trying to do is strike a balance of rigor to take existing research, plausible uses from clinical experience. What I will say is that we simply just need better and more research to answer these questions. It is entirely plausible that people that are on a certain level, certain dose of marijuana over time can get metabolic syndrome. It increases appetite. And I'm sure it alters diet. And so if you set up a system for surveillance through observational data sets, you can assess those risks over time. We have a limited ability to do that now, though, because, again, no federal research funding. Researchers are scared to store it and investigate it because of fear of federal enforcement. And so we're seeing some more laxity on that from the federal side, but until you get descheduling, where the DEA says this is no longer a Schedule 1, it's a Schedule 2, you won't get the type of research you want. Yes, on the left.
So, I treat patients with painful peripheral neuropathy, large majority being diabetic neuropathy. And I've reviewed the literature, and if you look at, for example, the sodium channel blockers, the calcium channel blockers, like gabapentin as an example, versus medical marijuana, the effect seems to be somewhat similar when you compare the articles, but it looks like there's more side effects from medical marijuana, to be honest. When I've looked at the literature on gabapentin versus medical marijuana, it looks like similar effectiveness, more side effects with marijuana, so I haven't been exactly enthused.
Yeah. So that very...
I'm not commenting on any other
No, of course. Yeah. So for folks who may not have heard the question, the literature seems to point out, and clinical experience seems to point out that your sodium channel blockers, like calcium channel blockers like gabapentin versus medical marijuana, both equally similar benefit, higher side effects for medical marijuana, especially in the acute phase. Certainly that, if that's your experience, I think starting with gabapentin is a good thing for these patients. For those patients for which it doesn't work, and I've had patients where gabapentin hasn't been efficacious, have this in line as a second alternative. I mean, I think, again, these decisions need to be made by people at the point of care, clinicians who know how to treat these conditions and use their best judgment to do so. And I think if that's your experience, that may be reflected over time in better research and more publications out there, maybe a good second line treatment. Or we may find that the side effects are similar. But I think we need literature, I think we need more information, but that's an interesting insight. Yes, up there, thank you.
So I remember that for the beginning of the year, for the summertime, that medical schools in Pennsylvania were approved to work with marijuana dispensaries and then possibly do research with that. Do you think that might happen similarly in New Jersey anytime soon?
Yeah.
Marijuana?
Yeah. So question was, there was an announcement recently that a number of universities, I think it was Jefferson, got funding to conduct research. And I think that was state funding. So I would love to see that. We have some policy ideas on the table for how best to do that, to fund more research. Again, that money would have to be state level. But I'm seeing some encouraging signs. So the DEA just announced yesterday, for example, that they're allowing for the importation from British Columbia of medical marijuana for testing at UC San Diego. So even the feds are starting to say, hey, this is something legitimate that we need to research and support. And so, as we start to break down those barriers, hopefully we can bring more federal support and funding as well. Yes.
I'm a pharmacist actually, so I have a little bit of a different perspective, and I've actually been looking a lot into Pennsylvania's regulations because I have a dual license. I have to say I really applaud what they've done as far as making sure that the studies and universities and all that are included as part of their plan, and I think that's going to help move things forward for everyone. I am a little bit concerned about on the dispensary level. So Pennsylvania states that, there either has to be a pharmacist or another medical professional on site to kind of go through, because the patients are coming in on multiple medications, to kind of go through their medication profile and to let them know about any potential side effects or other issues they may experience by adding this to their therapy. And that doesn't really seem to be the case with what New Jersey is doing right now. Is that going to be something that is going to be considered as, added to what we're doing now? I mean, I hate to think that somebody would be going into a dispensary or whatever you want to call it in New Jersey and just going to a layperson who considers himself a bud tender and, saying, okay, well, this patient has cancer and they're on 50 other medications. But, it's cool, you can take this, whatever. That's really concerning to me.
Yeah.
Is that part of the next, the regulatory phase, that they're going to add more
It's
professionals in the dispensary?
Yeah, it's a good question. So to summarize, shouldn't you have a pharmacist next to the professionals in the ATCs? You mentioned bud tender. I've heard budista and some other names for them. Again, something we might want to change. But shouldn't there be a pharmacist in there saying, hey, this is going to interact with, this benzo that you're on, or whatever it might be? I would love to see that. I think the program was designed such that the overall clinical profile, the responsibility of saying, hey, this is an agent you should try from a physician standpoint to see what other medications you're on, and recommending or not recommending based on the whole picture. Of course, pharmacists play that extra a very important role of having the most knowledge pharmacologically on what will interact and what won't. And what we're seeing is more pharmacists interested in this topic, pharmacists that are specializing in this topic, that I believe will naturally get into the business once it expands and once you're seeing more freedom to do so. What I've also heard is that pharmacists, because they don't have clear sanctioning from a legislative standpoint to be involved in the medical program here, they're afraid to do so, whereas physicians are clearly outlined in the legislation as being available and able to recommend it. So that would need to have some work from the legislative side, and I think I would support that. Yeah.
Question on that. So whether you're a physician or a pharmacist or any other medical professional involved in this process, what are the extra, liabilities as far as that goes? Does traditional liability, professional liability insurance even cover someone who would be working in this type of environment?
Yeah. So that's a good question. I don't want to speak out of turn. I'm not a lawyer. But if in good faith you are complying with state law and recommending it for a qualifying condition and documenting just like you would for other patients why you think this is the case, I don't think that risk should be viewed differently. Now, when if there's medical malpractice, usually that doesn't involve federal law as directly into the case about whether you committed malpractice or not. The intersection with the Board of Medical Examiners, however, is important. And so we've already met with them on this topic and made sure that there's standards in place for the right documentation. Again, not to be different from other agents that you would use for your patients. As long as the rationale is there, it's an approved qualified condition, and it's your best clinical judgment, that should be considered similarly. Yes, in the front.
From a public health standpoint, kind of getting some experience out of Colorado now, what are your personal thoughts on this legalizing?
Yeah. So there's an adult use marijuana proposal on the table that at a high level the governor supports, primarily for social justice reasons. And what does that mean? Equal use, equal illegal use, recreational use among all races. A 3-to-1 rate of prosecution and criminal justice interaction for the black community versus the general population. And also happen to be in urban communities, poor communities that suffer from this. And by the way, it could be as simple as a low-level possession charge that follows someone throughout their life, affects their employment prospects, affects their educational prospects, and really just prevents them from thriving. And so that is the motivation behind the administration's support for adult use. Of course, my hat as the public health official for the state is to mitigate the public health risks associated with that. So learning from the lessons from other states, particularly Colorado, where you saw an uptick in car accidents associated with people driving under the influence. How do you get the message out about that, the fact that that should never happen, and that how do you equip law enforcement with the right tools to detect high driving? All of that would be within my scope and my colleagues in the administration to figure out the best public health approach. So, to say that adult use legalization is supported by the administration is not to say that we wouldn't do everything we can to mitigate the public health risks and to educate people from the risks of use. Yes.
I have a more simple question. I'm a little fascinated with the new vaping pods, because with the upsurge of vaping in teenagers, it's astronomical, and the FDA, as you all know, came out with their recommendations recently. What's in it? Is it more CBD, or is it still THC? What's the psychogenic effect of the pods? Because now schools are banning all thumb drives and USB because
of
they don't
it.
know what's a USB and what's a vaping pod. And I've had industrial chemistry students already figured out how to vape just about any drug, because there are methods where you put your own chemicals in. So I'm just curious if that becomes more use, might worry more about it sitting in the house than some of the other benefits.
Yeah, so the question was around vaping, the changes we made to allow for vaping, and whether that has a relationship with the content of THC versus CBD. So Assistant Commissioner Jeff Brown, correct me if I'm wrong, but I believe that it has nothing to do with what goes in to the vape cartridges that we have introduced. That could be a high THC to CBD ratio flower. It could be the opposite. That is an independent thing. What we were finding is that people were taking the topical formulations and putting that into vape cartridges for other types of things that you vape, including tobacco. And we didn't know exactly how that was being delivered to patients. And so while we don't encourage explicitly vaping in and of itself, as I mentioned, oral administration is prioritized, then vaping, then smoking, smoking being the last. We wanted to make sure that we had some level of control and understanding of the delivery method, and that's why we introduced the vape cartridges for patients who prefer to take it that way. Anything to add, Jeff? Or?
I would just, I would add that the cartridges tend to have a higher concentration of medicine overall versus what you would find in flour, and so it's actually, it allows patients to get quicker relief with less smoking. So, and additionally, in terms of ingredients, it's all food grade material that goes in. We they have to approve. We have to approve the ingredients that go into these cartridges. But a big part of the decision was it's a higher concentrate of active ingredients. It allows for relief quicker and with less smoking.
Yes, on the left.
Thanks for your presentation.
Of course.
I'm a chronic pain doctor. I see a lot of patients with chronic pain, not malignant pain, who are on high dose opioid therapy. A lot of patients who have taken on as legacy patients higher than 90 morphine will equivalent. So my question to you is, are there any guidelines or any medical body or anything like for these patients to, if I want to start them on marijuana therapy, is there any guidelines on do I eliminate opioid therapy completely? Is there a goal to reduce by a certain amount? Do I consider first-line therapy if I'm treating a patient who has chronic pain? I've identified it. I've tried multiple non-opioid medications. They're not working. Do I start them on an opioid? Do I go this route? Like, is there any guidance on this?
Question was any clinical practice guidelines, pain physician, for how to approach its use for chronic pain as a first-line agent, when you introduce it, its interaction with opioids. No federal sort of professional society generated clinical practice guidelines. Usually those require some body of evidence and folks getting together and first of all endorsing its use, which is not fully bought in a lot of the country. But I will say that there is literature supporting its use for several types of chronic pain. And it's a logical goal that if you have somebody with chronic pain on high doses of opioids, that you would introduce it as an alternative agent and titrate them down on their opioids. And I feel like you do that as a pain physician for other things. And that's like your area of expertise. So I would love to get a bunch of pain physicians together, understand what we can do better in terms of guidelines and information to encourage more use. So thank you. Yes? I'll keep going until I'm told to stop, by the way. So whatever you guys.
Whatever your schedule is.
Okay. I have a few more minutes. Okay. Sorry.
Curious for possible legalization in the state looming. I know the legislation is moving forward. How do you still incentivize medical patients to consult a doctor and possibly contribute data to a wider, system of research, and instead of just going to, a clinic that doesn't require a prescription to access it?
Can you repeat the beginning part of your question?
How do you incentivize possible medical marijuana patients to go to a licensed doctor and go through a health screening to obtain their medicine or marijuana if legalization occurs, as opposed to just going to any clinic and getting it without having a health screening?
Question is, what are your thoughts about incentivizing patients to remain in the program or to enroll in the program in an environment of adult use legalization? Where it may be down the street, you can go get it for cheaper at a marijuana shop or whatever. The key thing here is around, number one, assurance of the strain and the quality of that strain that a patient is getting. Number two, the clinical consultation that they will get for what is likely to work, and the interactions with other medications, as was brought up before, that both the physician gives you and the professionals at the ATCs will give you. And again, assurance that you're not getting a contaminated sample. Because when you buy from the illegal market and even from a legalized market that doesn't have to go through as much product testing, you're not exactly sure what you're getting, and that's especially important from a therapeutic standpoint. If you're using it for recreational purposes, people consider that less of an issue. So those are the main selling points now. The real sustainable selling point will be cost at the point of sale and coverage of their costs that patients will need to spend. And the reality is that in an adult use market, it'll be cheaper to just go buy it from a recreational provider, from a recreational vendor. And we need to think about policy solutions to cover the cost for medical use. And that will really, I think, sustain the medical market over time.
The commissioner will take one more question.
Thank you.
Okay, if not, I'd like to thank him for such a comprehensive.
Thanks so much.